Hi, good evening. I am Landa. Presently, I am a nurse at one of our hospitals in Trinidad and Tobago. So today I'll be introducing a electronic health record system to be used in one of our hospitals in Trinidad and Tobago. Our healthcare in Trinidad and Tobago is managed by the Ministry of Health. In 1994, it had a reform, and the Ministry of Health broke down the different hospitals and placed them into regions, known as the 5 regions. We call it the Regional Health Authority. So this one in particular is called the North Central Regional Health Authority. One of the hospitals within the region that I am going to speak about is the Wendy Fitzwilliam Pediatric Hospital, which is located at the Eric Williams Medical Sciences Complex. The subunit in discussion this evening is the Pediatric Outpatient Clinic, or what we would shorten and called the POPC Clinic. The POPC Clinic is basically run by a manual filing system. From the very first point of care, when the client comes as an outpatient from various departments, they would meet with our administration staff. At this counter or station, the patient will give their basic demographic information: age, name, sex, address, phone number, next of kin. At this area, a paper folder or file or record will be created and be given to the patient. The patient then physically walks this document, this file, down to the nurse's station, which is the second point of care. Once it gets there, the nurses will do vital sign or any other clinical procedure, and the file will then be stacked up on our counter, and the patient will wait to see the doctor. Once that has taken place, the nurses will manually then walk a file to the various doctors, and the patient will be seen. The patient will be given a hard copy of a prescription or any other referral letter to be taken to the various departments manually or physically by themselves. So on the way out, they would book a follow-up appointment, and that will be written into a folder and placed in a cabinet. Once the patient collects these paper documents, some get filled or some doesn't, because they get lost in transit because our institution is huge. Sometimes it gets to the department deplorable, or sometimes because documents are manually given, then sometimes tests are repeated. Sometimes clients miss appointments because they never dropped it off. So basically, our paper system is run, but it creates a lot of difficulty and challenges for us. It creates illegible handwriting, inaccessibility to receive patient records, poor communication, and overall fuss. There are various departments within the POPC clinic. Just to name a few, the two main settings are the medical and the surgical clinic. Then we have the interspecialty areas such as endocrinology, gastroenterology, hematology, cardiology, orthopedics, urology, neurology, ophthalmology, just to name a few. So we're going to introduce our health information system, which is an electronic information system. So it will be an electronic health record system. And these are the various departments that will use it: client, administration, nurses, physician, pharmacy, radiology, and the laboratory. In order for us to bring this system into the clinic and for it to be accepted, we have to create a new setting while trying to get rid of old cultures and resistance to the change. So the first thing as a consultant I will do is bring in a change management team. According to Lewin's change management model, there are 3 stages: unfreeze, change, refreeze. Unfreeze is where in the POPC clinic where I would try to develop a new culture, a new way of thinking, a new way of creating a new workflow. So I would identify the issues we have with the old system, such as poor communication, illegible handwriting, medication errors, or unavailability of getting files. And then I will show them the benefits of the new system and how to eradicate these issues. Second stage is change. This is where the system is actually implemented and you allow clients time to adapt to the new change, to make it simple, and you try to find fit between the business organization and IT to bring it as simple as possible to the end users. Refreeze is where we actually use the system on a day-to-day basis with training to get it to stick. Then we have the business re-engineering process. It comprises of the administrative task. This will be done by the clerk. This is the patient demographic and basic information that will be documented. Medical tasks, this is done by the physicians, such as diagnosing or reading of referral letters. Complementary tasks. The complementary tasks are usually tasks that are done by the nurses and the doctors. The complementary staff, the nurses and doctors will incorporate the whole supportive teams such as the radiologists, the laboratory technicians, the pharmacists. So we would support and with assist and come together and make decisions. Then we have treatment and healthcare. This is where the physician has orders and the nurses will follow in terms of, let's say, he may have a procedure that needs to be done. We'll come together, we do it, that will be able to document, I'll be able to document, and then we come together as one unit. The patient to be seen by the specialist, this is where referral letters will be given. So therefore, with the new system now, we will have to give any manual copy. We could just shoot a message to the various departments and it can be done in real time. Then we have the benefits of having a business re-engineering process. It will be customer-based, it will add value, reduce cost, job satisfaction, file accessibility, real-time, can decrease medication error due to illegible handwriting. What is very pertinent to the implementation phase is the strategic information system planning. This is where we gain strategic advantage over the RHA. The planning is so important that we look at the step-by-step issues, barriers, things to be implemented that can be eradicated. At the POPC clinic, it is an asset to the client and the health professional by enhancing the importance of the system. So the importance of our system will be to create quick access to file, real-time care, job satisfaction, and quality care, and quality, not even quality care, but customer satisfaction, right? There are, am I going backward? I'm so sorry. There are 5 phases of the SIP project process. Strategic awareness. This is when they bring awareness to the client. You're allowing the client to be able to see, to identify the issues and the problems of the old system, but also to bring into awareness the benefits of the new information system and how things can happen in real time and how you can eradicate problems. And then we have strategic analysis. Strategic analysis at this stage is where you analyze the business environment. And you try to bring the system and the environment into fit. Then we have the strategic conception. This is where you literally bring about a visual example for the end users to see, to simplify, to show them exactly how the system is going to flow and how it's going to create benefit, right? I'm going to show you that in a minute. So you're going to see exactly how it's going to create an easy access and quick and smooth flow throughout our clinic. Strategic formulation. At this part is where you're actually formulating and aligning the system and the environment. Strategic implementation is where the new system will be implemented and to have a consistent use, to have a daily utilization of the new system. Who are the end users? The doctors, the nurses, the physicians, the pharmacists, the laboratory techs, every specific work, and most importantly, the client, our end users of our strategic information system. We are introducing a new system, which is the electronic health information system, and every single end user is important. If one aspect doesn't understand or doesn't find that cohesion, then it makes the implementation very challenging. Some of the features of the EHR are the health information and data management. Then we have the order entry management. Let me explain the order entry management. This is the implementation of the computerized order entry, or what we call the CPE. It allows the physician and the clinic to communicate electronically with supportive clients and staff. For example, the laboratory, the radiology, all the different departments, he can communicate and interact with them all at once using this one system. Then we have the results management. Once he contact the various departments or supportive staff, and let's say he asks for a diagnostic test like a CT scan, the result management is folder on the system will actually have the result right there within reach. So he won't have to wait for a hard copy, it wouldn't get lost along the way, or a test wouldn't have to be duplicated. So we prevent any redundancy at the same time. Clinical decision support, this is where decisions can be made. With people directly involved in the plan of care, we can come together and we can literally form decision and give order in real time. We will receive, at this case, let's say, the physician should order some type of medication, the system will alert him if the dose is too high, too low, or some type of contraindication or some type of allergy in case he may have forgotten. Then we have the electronic communication and coordination, self-explanatory patient support. Patient can learn things through that we might have a visualization on before they can go back and look at it and become educated. And for report and population health management, this is where the high-end managers can get information of our system to generate decision making and to create reports. For example, they can be able to see, let's just say, infectious or communicable diseases amongst pediatric children. They will be able to find this information there. So this first diagram is a little indication of how our electronic system is going to run. From the first point of care, or the first person that will interact with the system will be the patient. They can generate information to the system by giving them demographic information to the administrative staff, and then information can be redirected to them so they can view the information after. We can look at the medical surgical team, nurses and doctors. Information can be taken, for example, the patient name, age, demographic, which plays a pertinent part into the diagnosis. And then we can, after they are seen and diagnosed and tests are being run, information can be sent back to that system. The managers can access all this information, and then they can send back the information as a report to be stored on the system. And then we have the supportive staff, meaning radiology and pharmacy. They can see the specific page and what is requested by them. They can complete the test, and then the results can be sent back towards the system. On our level 1 data flow, so this is where we actually have storage. So each department can store information. So then, for example, if a patient comes in and they would have gone to the registration process and they would have been seen by the administrative staff in terms of creating an appointment, given the demographic data, where a unique patient identifier code was given, all this information can be generated and stored, so it can be used again, it can be put up, so it will be on the system. Once the patient is seen again, then the nurses can indicate of what plan of care, it can go to the system and then back to the patient again by report. It can also be connected to the doctor. The doctors, and then the doctors can then diagnose, assess, And he can also store and document this, and the patient can ask for a medical report. You just go to the system, and this can be generated. The doctors also can have intercommunication again with our supportive staff, such as pharmacy, laboratory, and radiology. So through the CPOE, he can send messages via to communicate to them what test he wants. They can now produce this test and send information to be stored to the result management system, and he can have access to this, and he can send it back to the system. The management, being the top of all departments, can have access to everything that was done, and they can generate a report to send to our Ministry of Health. They can detect immunization status, they can detect communicable diseases among pediatric children, and so forth. The EHR usability. According to TURF model, it must be useful, usable, and satisfying. It must be useful in terms of understanding. It must be usable, learnable, and very time efficient. It must be satisfying. The end users must be able to identify if the system is satisfying to them. Then we're going to have usability challenges. Organization and display of information, meaning the user interfaces and stuff is very poor. There's no fit. It is not specific to the clinic. There's no customization. It interferes with workflow. It creates more difficulties than solving the problem. Okay, the EHR hardware and software. These are basic components and requirements. Servers, workstations, laptop, tablets, smartphones, monitors, scanners, printers, storage, and backup, which is very important. Shredders, medical and diagnostic treatments. Our user interface, like let's say, for example, a patient is using a phone. We'll have an able to put the user ID and the password. Once they come into that, they should be able to go onto the NCRH icon. And once they open up, they should be able to see the pertinent information. So these are codes or encryption that is given to the patient that any other person would not have access to. Our doctors and nurses at the clinic will be given tablets as we move around on iPads, and even the different departments and supportive staff. So once you click on your icon, nurses or whatever, your patient will be able to open up. You'll be given your code as such too, and you will only have previous information that is important to you. Our pharmacy will have the same setup. They will have their in-house desktop, and they should be able to see their pertinent information. Once again, patients' confidentiality and privacy, they will only be privy for this liable to them. Storage and cost, the system can be hosted internally or externally. However, our POPC clinics will be hosted externally, because we compared cost. Internal cost is high initially, monthly fees. Externally, which is pay as you go. Staff will be able to be trained and to perform maintenance, whereas externally the vendor is responsible for the upkeep. They're capable of connectivity, but we share with other organization. Connectivity, they can control the speed and connectivity, but we share with others. This is one of the internal infrastructure of the external and the internal use. This is the LAN is the local area network, and WAN is the wide area network, meaning externally cloud. So you have a client interface network presentation, meaning a server, the app integration, and then it creates database. EHR cost. EHR is very expensive. The hardware, meaning the laptops, the iPads, the computers and stuff are really expensive. Then we have the software. We're talking about the design and the customization and stuff will come at a cost. Or the research has shown that it's $2,500 per provider, per user. The implementation phase costs a lot of money because you have to pay people to train staff. You also have to provide training and support temporary reduction in staff productivity because it may slow down. And then the averted cost might be like for copying, and then they might be running this new system in parallel of an old system, so it will cost initially. The benefits will improve quality, improve patient safety, improve patient education, improve utilization of tests at the POPC clinic. Some of the threat is malware, cloud threat, insufficient encryption, employee and insider threat. Post-implementation. So once it's implemented, you must continue to train and observe staff. So you have a testing score and an implementation, place a testing strategy, and then system rollout. What is that? Is basically saying that even after you implement the system, you would need to still observe how the system is run. So basically we have what you call a dry run of the system to ensure that everything is working. This dry one will not be done by the whole system being implemented. So it will be implemented in parts, so department by department. So you can train people as you go along to ensure that each specific area is being run properly and to find out of any problem. You're looking at the storage, you're looking at the backing up, you're looking at the security. And this is a very crucial stage. Some of the challenges and stuff is observation. The work plan, they must keep up to date. They must know which department is actually scheduled to do the dry run today to implement in a live semester. So you must know what is being implemented at what specific time to prevent confusion and mix-up. And you have to keep a close observation. The reason why you're doing it in parts is to ensure smooth running because you want a successful end. So in conclusion, the change process, the business redesigning, and security is very important to the implementation of a new system, especially in a healthcare environment. We're looking at patient privacy, confidentiality, we're looking at the backing up of information. If something should happen and the system should malfunction, how are we going to recover? The system is very important because it will provide competitive advantage and customer satisfaction through real-time access, file accessibility, decreased medication errors, just to name a few. So thank you so much, and do have a blessed and productive evening. Thank you so much.